And we're going to move on to our next panel that has now been revised. Thanks again to Princess Fiona. One of our panelists, Dr. Linda Shin from Memram Cook Moncton area, has had to cancel due to weather. So that leaves our Dr. Sarah Gander as the panel this morning, but I have absolute faith in her that she is going to handle that just fine. And I believe she's going to be calling on another couple of folks for a little bit of insight and to offer some of their expertise as well later on in her presentation during the discussion. So without further ado, I'd like for you to welcome, please, Dr. Sarah Gander, who is a St. Johnner, as she alluded to. She has been living here for several years, has gone to Memorial and McMaster and UMBSJ. And yesterday when I was out for a brief walk, I actually stumbled upon her sweet social pediatrics clinic, which is actually just a couple blocks away. So Dr. Gander, St. John is very fortunate to have you here in this hometown, and as are we, to talk about your social pediatrics clinic and all the wonderful things that you do there. So please come up on stage and you can come and do your presentation.
Thanks for having me, you guys. And so welcome to all the folks that I don't know, and then I have some lovely support here actually from some of my team that I can introduce throughout the presentation. So I think I'll hopefully be able to speak a bit to what Elaine Deschênes would have spoken to as well. She's a mentor, she's a friend, and really she had the first community social pediatrics site in New Brunswick, and I took her lead and am a few years behind her in creating our center here, which has been up and running for a couple of years. So hopefully I can do a little bit of justice to that presentation as well. But don't worry, I won't stand up here and speak for 90 minutes, just me. So what I was asked to speak about today is actually one of our programs that's under the umbrella of community social pediatrics. And I'll get to a place where I can define social pediatrics for you, because already two people have said to me, like, what is this term, social pediatrics? And I'm a pediatrician, so as was mentioned, I grew up in St. John. I went to UMBSJ, I went to Memorial. It was actually Queen's University that I did my residency in Ontario. And then in 2008, came back and started my practice here in St. John. And so for any of you who have seen a pediatrician or have children that have gone to a pediatrician, in New Brunswick, we're consultants. We're not doing primary care, so you're not necessarily coming to me for vaccines and for well baby checks, but what you're coming to me for is largely referrals from family physicians. The system was set up so, I would take a referral largely from a primary care provider for things like constipation, belly pain, headaches. And when I started my practice about 15 years ago, that is what the referrals were. And then very quickly, it's evolved to probably be closer to 60 to 80% anxiety, ADHD, school failure, behavioral issues, children who have been exposed to drugs or alcohol in utero. And I also cover the hospital. And so when I was actually training in Kingston, we would go up to CHEO, to Ottawa, to do some of our training. And when I would be in Ottawa, they would do like presentations about some of the curriculum that we needed to learn. And I remember they talked about neonatal abstinence syndrome, and it was like the big slide came on, like NAS babies. And they said, you might see a couple of these throughout your career. Meanwhile, I was working down the road at Kingston, where there's, a large incarcerated population as well. And we were admitting one of these babies a night. And then I came to St. John, and sadly, that has been my experience here too, is that almost every night you're on call, you're being called to assess babies who have been exposed to largely opioids in pregnancy, because that tends to be what's triggered to be on the lookout for withdrawal, but withdrawal of all sorts. And then, so just recognizing the population that we were serving, it actually became very, very frustrating, because as a pediatrician, we weren't trained to deal with this at all. Like, I kid you not, 1 month of psychiatry training in a 4-year residency program, of which everybody always took a vacation week during that time. So it was really 3 weeks. And, it was more or less like, oh yeah, if you have a suicidal kid or you have a kid who's like going AWOL, consult mental health and like move on with your day. Well, I'm sure you all realize too that that's just not that's not a plan that's going to play out well for kids, just based on resources, but also just like the sheer volume of kids who are struggling and need difficulty. Or having difficulty. And so for me as a pediatrician, of course, much like our speakers were talking about before, you're really trying to go upstream, right? Like as a doctor, you feel very downstream. Especially when the adverse childhood experiences research started really coming to light, and we started realizing the long-term, not just psychological and mental effects of trauma and toxic stress, we began realizing how that was influencing people's actual medical health. You realize that as physicians, if you're getting people with a heart attack or diabetes or cancer or an overdose, you kind of feel like you've missed the boat. But what happened to you? Like, what brought you to this place? What's going on for you that's brought you here? And so I felt so privileged to be a pediatrician and see that I had the opportunity to make more of an upstream approach. And so I was asked today to talk about one program that's under the umbrella of Community Social Peds. But since Fiona gave me all the time in the world up here to talk to you, I will talk to you about other things too, and stop me if I'll stop if people start yawning and like falling out of their chairs, of course, but feel free to interrupt me at any time to ask questions or to clarify anything, because this is what I do every day, and so it gets me really excited. So this picture is there because when you're a pediatrician, because we talk about silos, dare I say that word, but like medicine is siloed too, right? So if you are pregnant and you're taking care of somebody who's pregnant, so you're a family doctor or you're an OBGYN, literally the baby comes out and they hand the baby to me, and then, I'm in charge, I'm the pediatrician, now I'm in charge of the baby. And you'll hear terms like, how are we helping people from like cradle to career, or this trajectory over a lifespan. And what I quickly realized as a pediatrician was that it's not cradle to career. It's conception to career, and it's arguably preconception to career. And so if we're not growing healthy babies, if we're not supporting pregnant women and their support network, then we're not growing healthy babies, and I would argue are already behind the 8 ball when we're trying to build healthy communities, which is really the ultimate goal, right? People reaching their full potential, healthy people, healthy communities, and that generational influence carries on, and we're able to change, things over time. So slides are always a little bit busy, but when I'll go back to community social peds in a bit, but the parent-child assistance program, so whenever you're trying to start these programs, like you guys were saying, the panel before, it's like, well, where are the programs? Well, when you're somebody working on the front line with people, you are also looking for the programs, right? And I just have this need to then find the gaps and try to fill them. And so one thing I really noticed when I was trying to help people from kind of conception to career is women who use drugs and women who used alcohol during pregnancy. And you don't have to hang out in the hospital very long to know, to hear really awful stigmatizing things happening to people, right? Like I've heard the nurses yell out, double glove girl, she's got hep C, or or the eye roll, or even like the nonverbal of methadone and you find it's a culture, and it's not right, and it's not good, and it's toxic, and we're working to change that, but regardless, it is there. And I saw a lot of it. And then I had babies myself. Now, I didn't use drugs or alcohol during pregnancy, short of, the sip of wine at Christmas that felt like it was an okay thing to do. But you realized how hard it is, the societal influences. And my score is like maybe 1.5 if I stretch it. So then you look at some of the women that we're working with and the circumstances and the difficult living circumstances that they live in and how difficult it's been. So when I had my babies, particularly my second child, who turned 6 in January, I had a really hard time. I had a really hard time after. I was really anxious. I don't really know where it came from. It's just, you don't know sometimes. And I'm so lucky, right? I have my mom. I have a wonderful partner. I have a sister-in-law. I have beautiful friends. And there were these moments where I'd look around and say, how the frig do people do this? If they don't have the person they can call at 2 in the morning to say the baby won't stop crying, or that sense of, the mood changes, the anxiety changes, the loneliness of that time if your baby's not feeding. And those are just realities of being a new parent. And like I said, my husband, Steve, is he's jumping up in the middle of the night to help out too. He's a good man, but it's just, I had all the boxes checked. And still I was like, huh. And then I would meet my patients and I would just, there was so much transference, right? I'd just be like, I don't understand how you're doing this. But who do you call? And they'd be like, well, I don't, I don't have that person. And so simultaneously at that time, the government of New Brunswick was offering a social innovation fund, and we were invited to put in an application for some funding for a promising practice or a pilot project about how to break cycles of intergenerational poverty. And it was a no-brainer for me. It's we need to create the aunties and the Grammies that you call when you don't have anybody else to call, because these are the families who, either, intimate partner violence comes into play, or the drug use or alcohol use, or, you're seeing tons of precarious housing, unstable housing in these families. We need a support network around these families, because those, in my observation, were the families that we were seeing then their children were having teen pregnancies or pregnancies that were affected by, substance use. So we created this project that had to have a research component because it needed good evaluation and outcomes, and we were granted that that funding, which ended up being just shy of $1 million for a program to really look at what it meant to have those support people there for these families. A non-mandated program, one that was voluntary, although women needed to disclose that they were using drugs or alcohol during pregnancy. But I didn't invent this program. So if any of you know about this literature out of the University of Washington, this is a promising practice that we literally went to Seattle, plucked out of the University of Washington, and then brought back here and created it in our local context. And that's the Parent-Child Assistance Program. And I knew we had the need, and these are crude numbers because, fun fact, healthcare doesn't actually look at any of these things as their key performance indicators, which is part of my administrative raison d'etre, because 120 women in the year of 2017 in St. John alone disclosed. So we asked women questions. So if any of you have gone to have a baby at the hospital, they're like, do you use drugs? How many drinks do you have? How many cigarettes do you have? It's not a motivational interview. It's more like a, do you do this? Do you do this? So these are people that just under those circumstances said, yes, I use drugs. 6 were undergoing detox in the city at the time. 36 had babies who are at high risk for hepatitis C. That was some of my early research in my career, was looking at vertical transmission of hepatitis C. Only 13 reported alcohol use, which is really fascinating. That's why I preface it with the way that the questions are asked. So I'm just I find that super interesting as a researcher, that you'd be like, yeah, I use drugs, but I don't use alcohol, right? Which could be true, but just seems a little unbalanced. And pardon me with the use of methadone clinics, but at the time, we didn't have a large population using Suboxone, so we were kind of casually calling them methadone clinics, which is now we would use opioid substitution therapy opportunities in the city. And so at any one time, out of our 5 clinics in the city, 5 to 7 pregnant women were there. So we knew that the need was there for women who were using drugs or using substances, were already somewhat engaged with the system, and could have an opportunity to be part of a program. And Dr. Newman, you'll appreciate this because I know that you care about the rooming in and the opioid withdrawal and situations like this. The Canadian Pediatrics Society finally was recognizing, again, this is how old I am, when I went into training, if any baby was exposed to anything during pregnancy, it was immediately taken from the mother at birth, brought into the NICU for observation, right, to check every little sneeze, every little loose poop, every little thing, to see if they're withdrawing. Now, we thought it was the best thing at the time, right? We wanted to intervene early, and if anybody's gone through withdrawal in their life, it's not very nice, so we didn't want that to happen to babies. But then the evidence started being like, wait a minute, maybe the most comforting thing for babies is to be with their mom and skin to skin and rooming in and breastfeeding and all the like beautiful nurturing things that would be nice for anyone. And that also was an opportunity to have what is called the golden hour. So I have had 2 babies in my life, and there's this moment of time after you have the baby where the whole world stops and nothing else matters, and that in research is about 60 minutes before you maybe get hungry or realize you want to take a shower or something, I don't know, or somebody comes in and visits you and really, they shouldn't be probably at that time, or somebody comes in and checks your vitals, but there's this 60 minutes where the baby's on your chest where nothing else matters. Your trauma doesn't matter. Your life, the life circumstances are not there because you're just falling in love with this person, and that's really important because that's really important for attachment. So what I know as a pediatrician, being on the receiving end of those babies in those rooms, is that I have never met a mother that didn't have that look of I would do anything for my baby right at this moment. And it is such a beautiful moment to engage in a conversation about, what can we do to support you to make sure that this is successful as possible, and what do you need, and how can we build that as part of your action plan, leaving hospital, even if you know that baby might not be going home with that baby, or that baby might not be going home with that mom. How can we make that as positive as an experience as possible for attachment, for her mental health, for the baby's mental health? Because right away those neural pathways are being formed, and that's the kind of stuff that I see 15 years down the road, 10 years down the road as behavioral problems, as trauma, as developmental trauma, if we're not working hard to create those really positive early childhood experiences. And the opioid crisis wasn't going away, right? So the neonatal abstinence syndrome was going from, in 2016, 2017, was up almost 30% of the, in the country. And so these babies, this was not slowing down. And again, these siloed services are what's here for our families, right? You go to obstetrician, you go to primary care. Here we have a beautiful public health program in New Brunswick. And then in St. John, we have First Steps. So I don't know if I didn't recognize anybody here from First Steps, but we have a housing facility here in St. John where young moms can go and stay and be safe, and there's some programming there and stuff. So there's these opportunities there. Then, we're having social development, community organizations, and then there's our addictions and mental health, but we're not talking to each other very often. And there's not a lot of just even the Privacy Act is annoying, right? Because sometimes you just want to pick up the phone, because we all know each other, we all work here, right? So it's just sometimes you just want to pick up the phone and be like, Kelly, I know that you know this person, and I know this person, and, how can we do this? But you can't do that. And so how can we create somebody who could navigate that in a way that could be supportive? Because there's some really, really, really good resources out there in the community, but sadly, our patients don't always have the capacity, but also just the social agency and time and space to be able to access them, and they need that navigation. So this is not a crowd that needs me to go through all the barriers to care for women who have substance use and addiction issues. But of course the negative stigma, of course negative experiences, not even just as adults, but their own childhood experiences, whether it be with child protection, whether it be with the justice system, whether it be with the healthcare system who hasn't done right by them. Of course the social determinants of health. If you can't afford a lawyer, if you don't have a bedside table to put your contraception in or your medication in, if you can't afford for the baby to be able to have all the things. Inconsistent means of communication. So that's actually a big challenge for us in trying to service folks. So, we have these little mantras that are myths and like untruths. So I hear all the time like, oh, everybody has a cell phone. And maybe it's like a drug thing. They're like, if you use drugs, then you probably have a cell phone because you have to get your drugs. But I think that's really judgy too, because we've done nice studies that show that actually a third of our patients don't have a cell phone, and or what they'll use is like Wi-Fi, free Wi-Fi, when maybe they'll have a phone, but they don't necessarily have it hooked up. And so then all of a sudden we needed to break down barriers of communication, which in the healthcare world, I don't know, we still use fax machines, FYI. And we call people, and has this ever happened to you? Oh, I called you, I left a message, you didn't get back to me, so we closed your file. So this kind of thing, we needed to work through this. And of course, housing, of course, transportation issues, the siloed services I mentioned, and then really just again, that social agency, the ability, you have to have a lot of space and time for personal growth. We might read a nice book about personal growth or go take a course or something, but if you don't know how to put food on the table, that's not where your priorities are, or you're trying to get your children back, or the school's calling, kicking your kid out and putting them on half days, this sort of thing. You don't have time to really think about, you know what, I really would like to go get my GED, this sort of thing, or I really would like to, improve my situation in some way. So again, we just end up with these cycles. So the vision was really about, I think we've heard a lot about coordination today, was supportive coordination. We believe really strongly in a harm reduction approach, which I'd love to hear from the crowd if there's different values and beliefs around harm reduction, because nothing that we do requires anyone to be perfectly sober, perfectly abstinent. It's always easier to talk to people when they're not really high at that moment or really drunk at that moment. But we've had lots of women who've slept it off in the back room for a little bit, or we've had to call and take them to the hospital and things, but then that's just sort of part of our rest, that moment of intervention. But very much a harm reduction. What can we do even during pregnancy? What are we doing to have less drug or alcohol exposure during this time? And really, because at the end of the day, we want to build trust, we want to talk about a mom's goals, and we want to build healthy babies and communities, and really so many, really all, of our folks are dealing with so much trauma and toxic stress in their lives. So that's the Parent-Child Assistance Program. So these numbers, because they had me do the slides in the summer, are actually not even the numbers that we have now. And these guys are going to kill me because my team's actually here. And so I'll probably just, rather than have you stare at words, I'll have you stare at their beautiful pictures. I know, they just gave me the eye roll. So what it actually looks like is that when women are enrolled in our Parent-Child Assistance Program, which I didn't originally love the name of, but if any of you know Therese Grant and the team out in Washington and the legacy that they've had born out of the FASD recognition 30 years ago, and has evolved to be that and all the drugs since, and you fall in love with the work that they've done, we couldn't help ourselves but to carry on that legacy by having the first East Coast site of the Parent-Child Assistance Program. So and this is a team of really sort of diverse backgrounds. It lends itself to a social work kind of vibe, so Holly, who's here, is a social worker by trade, had, 30 years, Holly, in child protection. So maybe and just has such good understanding of the system. Kelly, who I met when she was working with the newcomers, and we had many of the Syrian refugee population coming in. That's how I first met Kelly, and she has so much strength and understanding of our community. And then Haley, who's here with us too, who came from a similar program in Alberta and is living here in St. John. And then Joanna, who sadly just moved on to work actually for the Hilton, was our administrative office manager. And so this team is a team of people who are so passionate about being the advocates. Case manager was the word that they use in Washington, but really advocates for people, for the women. And, you know, the stories are, how can we decrease your heat bill by putting plastic on the windows? You know, how can I go to court with you and sit there so you have a person with you? How do I, you know, like, how do we make ends meet this month? Let's sit down and figure that out. You know, to everything from, you know, let me come in and play with the kids with you. So, you know, modeling some of that stuff. And it's just those little bits that, like, my mom did for me, you know, my aunties do for me as a mom, and that these guys really go over and above and really, I think, fall in love with their clients, and they're so passionate about each lady and what's going on with them and anything they can do to help. So, like, nothing's off limits, I guess, within the realm of safety. Lots of form filling out, lots of trips to Service New Brunswick for IDs and all these sorts of things that just are those building blocks to be able to access the resources that are in the community. And with that specialized lens of addiction and substance use and the trauma that many of our ladies have had. So in Washington, the primary outcome was actually a reduction in the number of births of drug and alcohol exposed babies, because that's a countable outcome, right? And so a lot of our outcomes are a little bit more gray than that with mums, and really alter the trajectory of the mums and their babies, mitigate toxic stress and trauma and the high risk of relapse, and reduction of negative health outcomes and cycles of poverty. And so the lower box here is some of the data out of Washington, and we were just so impressed with this. And not because the goal was abstinence, but because people were engaged and no longer needed to use the substances or weren't drawn to the substances because of the support that was there. And I'm sure you'll appreciate too, almost 80% of children living with their families because you were able to stabilize those situations. And here's just a really nice quote. Before PCAP, I never thought about goals. They showed me the right direction. They showed me that I am responsible, that no matter who I am or what I do, I am somebody, and it's never too late. And that is really the tenet of PCAP, which is, I'll just skip one and then I'll go back in a minute. Oh, shoot, it's not right there. Is really a goals-based program. So in a minute, I'll have a slide about, has anybody heard of the difference game before? Maybe the folks from Elsipogtog, Lori Cox does it. She has an Indigenous-based difference game. And it's literally a card of 35 cards. And when you sit down with a family or a mom, I use them with my youth actually in the clinic, is that you take these cards and it's it would make a difference in my life if. And there's the list, and there's a few wild cards, so you can make a few things up, but it's like, I have stable housing, I have a friend, I have these sorts of things. And that's actually the beginning of the conversation and really putting that ball in our clients' or patients' court. And it's really sort of saying, okay, let's list all of them, or like, let's pick the ones that are relevant. Now, of the ones that are relevant, let's pick the top 5, and what do we need to do to unpack that? What support do you need to get there? And then revisiting those goals as we go along. And, you know, the advocates would tell you that sometimes a year later, you're working on the same goals, and sometimes you're just like, all you did was unleash this wonderful opportunity by getting somebody a picture ID, because they didn't have the $35 to get a picture ID, which means you can't get a bank account, which means you can't get housing, which means you can't get a job, actually. So, you know, sometimes it's that $35 and somebody driving you to Service New Brunswick that unleashes this whole, you know, thing of opportunities. So again, and then you find more gaps because, you know, while advocates are working, you know, I'm a pediatrician, so there's lots of parents, and there's lots of different parenting styles, and there's lots of good ones and, I don't know, ones that could use some support. And parenting is the thing that, like, everybody wants to be a better parent. None of us are perfect parents. And strengthening families was really about how can we help model and give parents the opportunity to learn about themselves, to learn new skills, to have their families be stronger. Same with the kids. And so we created this Strengthening Families program. So anybody from the John Howard Society would recognize that term for a program for older kids, but we wanted it for these little babes that were born to moms who had some addiction issues. And so what happened is that we had volunteers in the community. We would cook a meal together. We would share a meal together. There'd be programming for the parents, there'd be programming for the children, and then we kind of come together and practice. And many of these families had never sat down and had a meal together before. Again, a lot of our volunteers were either moms or Grammies themselves, and so just even modeling that care of holding the baby and responding to the baby's needs was just really a beautiful thing. It was all about attachment and really being able to offer those opportunities for our families. So I thought I'd share some of the local data because we've just graduated a pocket of our moms because it's a 3-year program. And so for the Justice folks, this is for you. And so about 25% of women on enrollment to PCAP have some sort of outstanding charge. And so this does not go down to 0 at 2 years if you have a criminal charge and you're like going to jail anyways or like stuff's underway. But a lot of our, 25% of our women have these sort of outstanding things like court appearances and they don't show up, and then it kind of just snowballs and lingers, and there's all these sort of outstanding things happening that really they, again, just don't necessarily have the social agency to deal with. And so sometimes it's as simple as like just saying, no, we're going to go. It's not as bad as it sounds. You just need to show up and it'll be sorted and it'll be fine. And so within 2 years of the program, none of our women had any of that kind of stuff on the go still. And so that was just really helpful because, again, it's somebody saying like, no, I'll pick you up. I'll take you. It's at 9 o'clock, we're going to go and we got to be there on time. And just even being a face in the crowd of somebody to say like, I'm here to support you and we can debrief afterwards and see how it goes. Or who else should we try to get there and trying to coordinate some of that stuff or that kind of thing. And so we're really proud of that because we feel like not only, frankly, the whole cost of the program, if we save one person from going to jail and their kids going to foster care, pays for the whole thing for years. So it's just when you look at that cost differential, we get really excited when there's clear return on investment like that because that's what the bean counters like to hear. We had a really hard time with housing. And so I think it's fair to show the nice down lines, but also just transparent to show the straight lines that we have a lot of trouble. So this is all the elbow grease and sweat equity to try to get people into housing that you could imagine. Like this PCAP model and these women working for these families, like it doesn't get better than that. And they're sitting on the by names list. They're talking to people. They're, helping them keep their places clean. And it's really hard to budge. And we really hypothesize that that's because at the end of the day, they're just is not the physical units to put people into that allow them to live with dignity and have their children there. So just as I'm sure you realize, your house is not fit for the children get taken away, your check gets changed and your ability to have support gets changed to have a house because no longer are you eligible because your kids aren't in your care. But how do you then get a place that's good for your kids if you're not eligible for a place that is for children? Anyways, so on and on it goes. So there just physically there's some barriers around process. And so we're really trying to unpack this now as we move into what we fondly call PCAP 2.0, because the research project is done and we have some funding where we can do a little bit more outside of the realm of research and more what makes sense from our data, is really trying to figure out how to move the needle on this sort of thing. So this can be controversial in people, and I just want to be clear that we under no circumstances coerce people or insist that people are on contraception, but we hear a lot from people that there are barriers to having their choice of contraception and when they want to have babies. And in New Brunswick, it's very expensive to have anything alternative to like a Depo-Provera shot or a birth control pill. And if you don't have a bedside table, fun fact, it's hard to remember to take a pill every day, you know what I mean? And so like you're trying to work around with other means like a birth control patch or an IUD that costs $360, and so it was really, again, a navigation tool. What would you like to do? These are the options, putting out the options. And then, so we've had a large increase in the amount of women who, because they've chosen to be on some sort of contraception and wait till a better time to have a baby, are able to access that. So less unplanned pregnancies or surprises. So this is the difference game, and I thought I would just offer what we see as the top things that our ladies mention as making a difference. So isn't that interesting, dependable transportation? So for any of the folks in New Brunswick who may know Randy Hatfield, who's the executive director of the Human Development Council, when I first met Randy and I was coming in, new pediatrician, social change agent, all full of vinegar for making change in St. John, he was like, Sarah, what year were you born? And I said, 1978. And he goes to his drawer and he pulls out his master's thesis from UMBSJ, and the date on it is 1978, and it says, the need for accessible transportation in St. John, as a social determinant of health. And I was like, oh, snap. And he just looked at me and said, it's a marathon, not a sprint, Sarah. Cool your jets a little bit, because we need you to be in it for the long haul, And so I just think that this is a fascinating comment on how here we are, right? I turned 44 this year. So 44 years later, we're still talking about dependable transportation for folks as making a huge difference in their life. More education, money to buy necessities, a real friend, so you can read them there. And so these are the things that really came out on top for our ladies. So I promised a little bit on community social pediatrics, especially since Elaine isn't here. So PCAP, I talked about, that is sort of under our community social pediatrics umbrella as one of our programs that's very niched, obviously, to the specific needs of women who use drugs or alcohol during pregnancy. We've got a few dads, too. Obviously, they didn't carry the babies as their pregnancy, but maybe the moms are no longer involved or sadly have passed away, and then the dads have the kids and just recognize that there's an opportunity there to be able to support those families as well. So the research program for PCAP had to have some sort of just criteria, if you will, right? And so we blurred the edges as much as you can in the research world, which isn't much, but you had to have had a pregnancy within the last 2 years, or have a child under 2. And I'm a pediatrician, so I see kids to 18. And it's a heartbreaker to know that there's this beautiful program, because what magically happens when kids turn 2? Nothing. And those families might still have more babies, of course. So we really try to take the community social pediatrics model and learn a lot from the PCAP model and sort of meld the two together for children and youth all the way up to the age 18. And you'll see a picture of that middle circle. So somebody mentioned Gilles Julien, who for 35 years in Quebec knew how to get his butt out of his office and get on his bicycle and drive around Hochelaga in Montreal and say we should be meeting around the kitchen table, and the child should be there and the family should be there, and we should be making goals and plans together. And so he was the inspiration, which is now 35 plus sites around Quebec, fully funded sites, about doing this in the community. And Elaine, who is supposed to be here today, who's one of my mentors and friends, started the first Gilles Julien Community Social Pediatrics site in Memramcook, which is just outside of Dieppe in Moncton. And then a couple of years later, we hang with the same crowd, have a lot of like-minded ideas. We opened ours here 2 years ago in St. John. And what that model is not a referral based from just primary care. It's self-referral. It's referral from the courts. It's referrals from social development. It's referrals from teachers. It's referrals from other parents saying to us, this child is struggling. It's all about the child. It's all about that rights-based approach, their right to education, their right to feel safe, their right to be able to have good medical care and live in a healthy body. And so what can you do to help connect that in the community? So we have a social worker. So I have funding for a social worker right now for another 2 years. We have a big research team. We have a board of directors. We got our charity status last year. And we have a beautiful amount of volunteers who do everything from run Lego nights and art classes and creative arts therapy to donate money to pay for occupational therapy, because a lot of the children who we see who have had trauma and toxic stress in their life are going to have a lifelong need for services. It's just a reality. Just think of FASD alone. We know that when the Parent-Child Assistance Program got funding in Alberta, it was because they immediately recognized that having just one parent-child assistance program and the amount of FASD that could be prevented saved the government $14 million a year. And so they just wrote a check and made it happen. And it carries on to this day. And so if we can prevent the long-term needs, I think you guys said it really nicely. Well, you were talking about when Dorothy Shepherd was talking the other night about, an ounce of prevention sort of thing. It's just really important because these things are not covered by our public payer system. Medicare has a lot of unfinished business. Therapy, counseling, psychology, occupational therapy, speech therapy, educational assistance in the school, tutoring, teacher's aides, all the things, right? Like this is a lot of what my patients need. And it just frankly is not available. The cost of medications, FASD alone, if you look at that and look at the medication algorithm, at least half of those medications aren't covered by the New Brunswick formulary, and we're talking $150, $250 a month. So how can we create a community social pediatrics site that has a little bit of money on the side where we can kind of try to fill some of these gaps for people, but at the same time not always be the rescuer. We're always trying to do research to trying to change policy to empower people to figure it out. What does it mean to get a job that has benefits? How does that improve your situation, and how can we help you do that? So that's community social pediatrics in like 2 seconds, but it's all based on that sort of child's rights, child's voice, goal setting approach. So of course there's the awareness of what's happened to the people that we serve and where they've come from and what their story is. We're not great at understanding race-based differences. We're not great at understanding the Indigenous perspective. We're trying to learn. We're trying to be open to that. Our staff is always trying to do training and be open, because I think we, again, don't meet people where they're at with those sorts of things when it's a bunch of sort of privileged white people giving this service to people, and not all of our staff are white per se, but just when you're going into that, a bit of a power differential with our patients. So we're building community engagement groups, I don't like the word patient advisory because I don't want to be in an advisor group. I want them to just actually do what I say. So I want to be on I told you so committees. So when I offer opportunities for patients to come and give their perspective, I want them to be sure that we're going to listen to them and actually do it, that they're not just giving us advice and we're like, wow, that's not going to work. That they have choice and collaboration. And I think we all know that the true healing from trauma comes from connection. And so we do fall in love with our people a bit. We do probably blur the boundaries a bit. I've been to a few graduation ceremonies, birthday parties, heritage fair presentations in my day. And it's actually the greatest honor of my career to have a little one say, you came. And you just sort of think that is worth, a whole bucket of Ritalin in a lot of ways, because they all of a sudden realize that they're worthy and they matter, and that it's, again, our privilege to be able to do that. And, safety is a big thing in our community. The reason why we have our clinic just up the street is because that's a community that the child poverty rate is 47%. And I still kick it a bit old school and go to do some house calls and stuff. And the quality of the places that our patients are living are, defy any human rights, let alone the UN Convention on the Rights of the Child, and just are not fit. And they're not people living with dignity. And it's a huge, huge problem. Not to mention the 11-year-olds who are running the roads, smoking weed down Lower West because their school day's been shortened and their parents work, and so who's looking after them? So it's just a lot of safety issues, and I'm sure from a police standpoint, we're really trying to get to a place where how can we come together, like you mentioned, collaborate, and how to create safe communities as well, and not criminalize our families, so then they just get into this cycle as well. And of course, strength-based and skill building, because we're not there to do it for them. We're there to really drive home the message that they are able, they are worthy, they do have capacity. We're just here to be part of the team that gets them to where they want to be. And so they're there again. They love it. And so this is largely community social pediatrics and our parent-child assistance program, our Strengthening Families program. We're launching our planetary health program actually at our site. We've had So social peds is really a broad term. We use the community social peds model for what I've described, but social pediatrics is really this marriage between the social determinants of health and children. There's an international society. Planetary health is probably the biggest push right now in terms of really understanding what our roles are in climate change. We're seeing immigration, we're seeing climate refugees, we're seeing, the lack of green space in our communities, which is a clear determinant of health for children. And so we've built an outside clinic space in our back area, thankfully to a lot of donors, which is on Friday, on Truth and Reconciliation Day. There'll be a ceremony because we've partnered with some Indigenous folks in the community to really look at how our connection with Earth and the planet really goes to show how much more there is outside of ourselves and how important it is to be connected to not just people, but to the land. And I think that's really important as we're moving forward with kids and families to see how they can really increase their agency and their place in the community. So how long did I talk for? I tried to do the best I could.
I'm not even paying attention. I'm just in awe listening.
Right. We have some folks in the crowd who are also doing some really good work. I know you'll hear from Dr. Newman later this afternoon. I don't know, Adam, if you wanted to say any words about some of your efforts in Kingston. And then I'm sorry, because I have adrenaline going, the name of your colleague in the back is... Oh, okay. Do you want to give me like the signal? Because I know that there's some community social pediatrics absolutely is not my invention, and I think people have intuitively come to the need for community health centers for intersectoral work, and so we're seeing it pop up in other parts of the country just organically. Gilles, was the pioneer in Quebec. There's a site in Vanier. There's a site Minnie's Hope up north, and then I think we're seeing community health centers like you described, Adam, and your colleague, who's doing some good work as well. So maybe she could speak to that. Or did you want to come up?
Oh,
I don't know.
Sure.
We're just playing it by ear right now, guys,
Before.
because we're going off the cuff with the panel situation.
Luzanne Rodet is the director of the Family and Child Services in Kingston and a board member of Ontario Portage, and I have twisted her arm.
Yeah. Do you want to come and talk about your work and how, if you like, no pressure, right? Like. Please, yeah, you're welcome to come and sit, and then maybe, sorry, I walked away from the mic, and then we could have some nice questions and chat about anything you might want to talk about. But come on up.
Thank you.
Were you ready? No, you didn't. Did you know you were going to do this?
No.
Okay, that's all good. It's a safe place, I think. Nobody's fallen asleep or out of their chair, I noticed.
Well, I wouldn't mind if they fell asleep while I was talking, actually.
I think that's fresh water too. I don't know.
Oh, good.
It's not COVID water.
There's no lipstick marks on the glass.
Yeah,
So,
it's a good sign.
No, that's all fresh, just for yourselves.
so Tammy, do you mind if you?
No,
I'll
please,
just maybe
go
just
ahead.
tell people what we're doing up here, so they don't think
Yes.
we're all confused.
Please do.
So my name's Adam Newman. I'm a family physician by training from Kingston, Ontario. My current practice is focused on addiction medicine. And I'm going to be talking a little bit later about my work with opioid-dependent mothers and children. And I'm very grateful that Sarah didn't elaborate beyond the golden hour, because I thought she was going to scoop my whole talk, and she didn't.
Good.
But I work as a physician in the community in Kingston, and Luzanne, as I mentioned, works with Child Protection Agency and is also on Portage's Ontario board. But together we have been doing, I think, a lot of what Sarah was talking about is very familiar to us, because it's the kind of thing that we do in effect, de facto, even if we don't really have a formal social pediatrics program. Mm-hmm. And maybe I could just kick things off a little bit by saying, whenever I hear somebody talk about identifying the broader determinants of health and their importance in their need to be addressed in order to affect the health of an individual, I can never get away from thinking, well, if you want to go far enough upriver, shouldn't we all be involved in politics? And it strikes me that what you're talking about, for example, talking about the 44 years that people have been trying to get more affordable transportation in St. John, where do you sit now? How do you see that? And I realize you probably have to be careful about what you say, because you've got to work with the political system as it exists, but...
Yes. For sure. So there's a diplomacy for sure when you're dependent on like funding and friends and government to make things happen too. Although I think that there is a courage that has to be in any attempt at social change, and it's not really about me personally. I mean, I try to protect my programs in the sense that if, you know, the current Conservative government has offered me some sustainability funding, you know, you try to politely give them the facts and the outcomes so they don't have a choice but to support it. And then it's also a call to action, you know, like, and that's what's so beautiful about the research, because people don't like the word research, right? Like they kind of think it's, especially when you're working with, you know, for lack of a better word, sort of marginalized. I don't love the word vulnerable, but like people who have been researched to death and not really offered anything in return. And so the word research in the academic world, particularly in medicine, has a meaning. And then there's sort of the colonial meaning of research and what it means to, you know, count people and things. But at the end of the day, evaluation and outcomes are important so we can track what we're doing in the sense that we can, you know, God, I'm using all the COVID words, pivot. So we can at least like change what's left. I'm sure there's another one. Anyway. So what I promise when part of the conversation with policymakers is always, if I find out that this isn't the right thing, we're going to be changing it. And I'm not asking your permission for that. You know, so so that's one thing. And then the other thing is that we're doing this because there's a gap, and that gap is your responsibility. And so I'm trying to give them the data as like in their language. Like that's when I was mentioning the return on investment piece. That's a very powerful phrase for our current government. The Liberals have a bit more of the feels when it comes to things. Not that people aren't, you know, concerned, because they are concerned. But I think it's just learning how to speak the language a little bit too can be helpful. But then there's sometimes you just get like really pissed off, right? You're like what is the problem? Like just do it, you know? And so, so then I feel really challenged. I've been in administrative leadership roles in healthcare, and you realize how thick the bureaucracy is. It's actually not even about the individuals being barriers. You're just like, damn, it is really hard to get anything done. And so I think we just continue to push. I wish Randy was here, because for those of you who know Randy, he'd have a way better answer for that from the Human Development Council. Because, you know, even with transportation, it just seems such a no-brainer to me, even just bike lanes, for instance, or like things like that, you know, some of the other opportunities and outside thinking. We're not the only city that has problems with transportation. Like, has somebody not figured this out? You know, it's just that kind of stuff. So that's why I like promising practice. I'm a little anti-pilot project. So that's why when I talk about PCAP or like community social peds, I wasn't going to reinvent the wheel. I wanted to bring what had been proven practice and bring it here. And so I think government should be listening to proven practice because other people have figured it out.
Amen.
Yeah.
Well, I guess I'm just to be clear, I'm not suggesting that we all join the revolution. I realize, I think I'm speaking as someone who's not in politics, and I probably have an unrealistic idea of how quickly politics can change things. Right? Well, if only we were in politics, we could suddenly bring in affordable housing and bike lanes.
Oh my gosh, yeah.
That kind of change is incremental and takes a lot of
Well, Ontario has, Canada has 211, right? 211.ca. Have you heard of that, 211? It's like the website and the phone, like you can call and you can find out about all the resources in the community. Does Quebec have that too? Ontario's one is awesome, and it's like in 56 different languages, and you can call a call center and you can say like, I need help with housing, and they'll talk to you in Hungarian about housing. And so it's an amazing program, and it's actually really, really inexpensive. And Nova Scotia did a pilot project a few years ago, and they learned that it costs like $1 million a year to have this amazing program that has all the outcomes there. What did we do? We had a conference to talk about whether or not we thought that it'd be a good idea for New Brunswick, and how much would it cost. This was 10 years ago. And then last year they thought, okay, well maybe Service New Brunswick could do that. Anyway, so we it's so frustrating when you can't just say like, why can't we trust each other? So there's the trust between the people we serve and the people we're on a journey with. And then there's just like the trust of the people. Why don't politicians trust that us who see those people every day have half a clue as to what might actually be helpful? It's maddening. maddening.
Well, I'm hoping that Luzanne will give us some hope, because the reason I asked Luzanne to speak is about a project which is not a pilot project, as I understand it, which a new program in Kingston, which actually seems to be something practical and effective that's actually happening.
Yeah. We, it's new. It's only about, it's in its infancy. It's about 6 weeks on the ground done, but not counting the previous work. And I work for Child Protection, and I'm a manager of the team that's we call high-risk infants, but 0 to 2 now. And we know that children are most likely to come into care at that age in our I'm only speaking for our jurisdiction because I didn't bring stats from Ontario, given the time. And they come in because our statistics show that they come in for reasons of maternal addiction, mental health issues, and violence. And we are lucky. We have been working diligently in reducing the siloed effects of child protection functioning in our community. I think Adam's nodding, he can see that. We partner in our community because we do not want the sole responsibility of protecting our children, because that is not the sole, we are the end of the road. And so we came together with the United Way. I don't know if you have the United Way in, okay, and our agency, and we included the city because we thought that would help us. Even if they couldn't remove the barriers, they would show us the way, right, in that system that we didn't know of. And we hired a consultant and did a study, and we spoke to families with kids that age and the families that use all the services that we wanted to have in one location. And we got organized around lowering adverse childhood experiences, we call it ACEs, and increasing, the positive effects of the social determinants of health. So to that end, we have about 40 agencies that are going to come into this space. We are truly lucky that there are primary care physicians in that location who've said, if you have families that come in, we will, and don't have a doctor, we will take them on as families, as patients. So we're offering services to families, but that's not the predominant part of it. Like, that is one aspect of it, but I think what you spoke about today was about in the middle of the night, you're not going to call, Luzanne Rodet because I'm not at my desk and you can't feed your baby. You're going to call someone else. So we're hoping, and we've started to see it happen in the first 2 weeks, which was quite awesome. We have a child minding area. It's a big area. We want families to connect to each other, so that when in the middle of the night you can't call a professional, you can call the person next door. And they come in now, we have toys, they play, in the room, and they're talking to each other. And there's no barrier of no one's signing consent. It's just a community space. You can come in and play. Yeah. So it's really awesome. And in that child minding area, we also heard from families, one of the barriers to accessing services and talking to your mental health person or addiction services, which are there once a week, is that I have to bounce a baby on my lap or, that sort of thing. So we have child minders. The kids are safely just across the corridor, and they are looked after while mums can focus on what they want to talk about and not be necessarily distracted when the baby might throw up or that sort of thing. And aside from, I don't want it to sound like we have just United Way and our services in the city. We did, the committee that we struck up, huge Indigenous representation, Métis, we are on Haudenosaunee land, and so we have representation. We have maternal clinic from Indigenous Maternal Clinic that comes in once a month. We're trying to increase that. The Islamic Society, Muslims Society were on this group. We are very much working closely with the Queen's Medical Health, and we have placement students from sciences, nurse practitioners, and for the first time we have a resident who's going to spend a day with us. And I think that's
A medical resident.
a medical resident, sorry. And that's so important to us because before you get really busy in your practices and fall into the hospital and your private practice, people, you could see how our families live, and that is, a picture is worth 1,000 words, and I'm hoping they'll have that as they go on. And when people phone from Child Protection and ask for those references, you'll remember where the struggles are. The other thing about the services, it's not just the hardcore services from the medical model, but we're doing things like for the social determinants of health, lots of services around food security, free fresh vegetables, that sort of thing, and we're also doing resume writing. That's so we have employment services come in to do that service. And I guess the last thing I want to say is, I think one of the speakers spoke to it yesterday, is that we offer services for men, and we just started this group where it's one-on-one at the point of charge. If it's violence against women, we're asking or inviting that man to come in and talk about, okay, you're in this situation. What can we do to prevent a breach? How can we keep you out of jail? But mostly, how can we help you not hurt your family, right? So I could go on for a long time. Very jazzed about the things we do in Kingston, together with our community. But I'll stop there.
I mean, it's outstanding. We, with our sort of much smaller attempt at a similar, amount of services, it was really important to us too that we didn't duplicate what other people were doing, because that's the other dirty word in politics, right? Is duplication, because it's like the synonym is waste, I guess, and for them. And I've never seen any of our people be over-serviced, so I'm not sure where the duplication is that they're so worried about. But it is about using other resources. So we may not have all those things under the same roof, but it's about building connection, and it's about, how do we use what we know to be able to provide this service over here, and this sort of thing, and that connection is really important. We're really lucky to have Dalhousie Medicine New Brunswick here, so we have quite a few students who come through as well, and MBA students, and Dalhousie students, and social work students, and nursing students, and that's a whole other thing, whole other stream of having, and research students. And, coming through, because I think you're absolutely right. Like, there's residency programs in social pediatrics now. After you're done your pediatrics residency, you can do a fellowship in social pediatrics. Because really, you're right, there's a medical model to it, but equal to that is the social model, equal to that is the legal model. So community social pediatrics, by definition, is a medical social legal model, because at the end of the day, if your rights aren't being upheld, and like the ladies before us said, there isn't the opportunity to be well represented in the justice system, or you've been criminalized unfairly or fairly, and that's become a barrier, then frankly the rest of the work is made almost impossible. So we really look to collaborate with, and that's kind of one of our uncharted territories. So I'm happy to see some local folks here from the justice system. How can we have a couple lawyers on our board to try to help us understand how we can, when we're designing programming, when we're intaking people, when we're offering services, how are we ensuring that that's with a rights-based approach? Yeah.
So I was struck just by you mentioning the fact that not everybody has a cell phone, and it just brings to mind one group that we have, a program that I really want to make sure to mention and give kudos to. And do you feel that kudos is also a kind of bureaucratic COVID term? I don't. Somebody once chided me for using it. He said, "You sound like a politician."
Siloed.
Anyway, I want to give kudos to the Thrive program,
okay.
which is a program developed by the local community health center where the services hub that Luzanne is talking about is located. It was developed in 2012 under the leadership of Ron Shore, who was then working for the community health center. It's basically barefoot social pediatrics in a sense, so lay people who were hired to engage with women who were pregnant or were raising children and who were dealing with addiction. So their mandate is specifically, and at the time it was, I think the funding came from opioid prevention, opioid overdose prevention, so they said it was about opioid addiction, but really they'll see women who are struggling with any substance and who are trying to parent. And they exactly bridge between the health center and child protection, people who are going to fall between the cracks. And Luzanne and I were lucky enough to get some funding to do a pilot project, which actually justifies your scorn for pilot projects because it didn't really last very long and it accomplished nothing. But for the brief time that it was running,
They sound really good in an election.
so we had money to try to provide what would amount, the idea was what would amount to residential treatment for a woman who didn't have access to residential treatment while she was raising a child. And we had a counselor who did trauma-sensitive therapy with the woman. We had a case manager. They had access to an addiction physician for all the good that did them. We had food coupons and taxi coupons. And it was just phenomenally unimpressive for the first couple of months. Until we added, the single thing that we added that the women themselves said was of significant difference was a peer support worker. So a woman who was hired who had first-hand lived experience of addiction and who was paid to kind of be her buddy. It's because this woman was still not showing up for appointments and wasn't making it to her methadone clinic and wasn't. So this woman would go and show up at her door and say, "Hey, it's time, you got to get down and get your methadone, and let's get I called you a cab." And she would go with her and sit with her in the cab and talk to her and was her friend, in a sense, was her paid friend. And that was what made the difference. And Thrive, in effect, although the women at Thrive are professionals and they're community family support workers, they do that day in, day out, all day, every day. They go, and of course, unfortunately, it was interrupted by COVID, but they're back to doing home visits now and meeting women in person where they are, taking them to their obstetrician appointments and their pediatric appointments.
The PCAP program does.
Right.
COVID, was a nasty wrench in things, for sure. But thank God we were there, actually, because there were a lot of folks who we might have lost even, actually, if there wasn't somebody reaching out to them. And, sometimes it was the camping chair outside of the back window of their apartment, and I'd sit in the camping chair, and these are my patients, not the PCAP people, but, you're just sitting there talking to people, and so it was COVID safe, and I wasn't in their house, but you're just trying to find different ways to make it happen, because we were so worried about that social isolation during COVID, because that's just basically, pouring gasoline on trauma, really, if you're
Well, the
you know,
social network was so
and-
frayed and so
yeah, and
tenuous
addiction,
anyway
yeah.
before COVID.
So that's really, well, Thrive sounds a lot like PCAP in a lot of ways, and I think where we're seeing successes, again, you're right, with the, you know, support and just the regular support. And then, because some of that downstream stuff, like, and not that it's unimportant, but, you know, like food and like the rescue-y kind of stuff, is really important, but then again, it's like, we're really excited about PCAP 2.0, we keep calling it. It's because now we're ready to really like move out of what were the confines of our research project and the accountability to that specific funding source to say, okay, now we have money to do what we want to do because we see what needs to be done. And so we're excited to be a little bit even more innovative with it. And so we'll lessons learned from other sites always. And we just kind of look at our data and try to move forward. But so like for us, we really believe that support is needed in the early years, but definitely until school age. And so that's one thing, is expanding the age until school age. Because what I found, especially with COVID, and I have a 5-year-old, so I watched it happen with my own child, is that like he went to his first birthday party like 3 months ago. So we're, as a pediatrician, I'm on the receiving end of all these kids who like have no idea how to be out in public, and then they're coming to me for like ADHD assessments, and I'm like, no man, they've just never sat in a church pew, they've never had to wait in line, they've never, you know, the stuff that we, you know, that's how we taught our kids to do things, is that, you know, you wait in the exhibition line, or you wait, you know, you wait, or you're going to, you know, a service, or, you know, and kids learn how to sit. But kids are just screens and all this stuff. So we're combating all this stuff that is a challenge at the best of times for a lot of our families. So
I just wanted to say that one of the other positive outcomes in our community was that we did in our pilot project was that
crap on pilot projects. A lot of my funding is pilot projects.
was that we recognize that we helped the community, it helped the community recognize that we needed a residential program. That, you know, sometimes there's a limit to wraparound services, you know, so that was helpful because we could speak to them.
I was going to say that too after you said that, is that I would argue, and like I keep looking at my team, but like, would you guys say that a residential facility, either for women or for women and their children together, like that's what we saw in Washington, like residential programs where children could stay with their mother actually and be there, were enormously successful.